Stu, you want to take over?
Sure. Thank you very much, Joe. Guys, today I'm really pleased to have Amy Spetla here. She's the Director of Physician Relations at Stamford Hospital. She's here today. She'll be introducing the speakers that Joe mentioned earlier. We have an exciting talk today from 3 physicians who are here to discuss lung cancer screening and the importance of early detection. So Amy, welcome very much. Welcome to the 3 doctors, and the floor is yours.
Thank you so much, Stu. I appreciate everyone joining us today. So as Stu mentioned, today we're going to be presenting on lung cancer screening and treatments. Lung cancer is the leading cause of cancer-related deaths, and most of the time it is not diagnosed until you have symptoms such as a cough, chest pain, or weight loss. When detected early, you have the best chance to be cured, and quitting smoking is the best way to decrease your chance of developing lung cancer. So I'll just introduce our speakers, and then we'll get started. So let me just share my screen. Can you guys see my screen?
Yes.
Okay, great. I know you guys probably do a lot of these Zoom meetings, but for some reason there's always difficulties. All right, so our first speaker is Dr. Bernstein, and Dr. Bernstein is a Fairfield County native. He's been in Stamford since 2010 following training at Duke University and Mount Sinai Medical Center in New York City. He has a particular interest in board certification in interventional pulmonology, and he is also the co-clinical director for our lung cancer screening and lung nodule program here at Stamford Hospital. Additionally, he has a strong clinical interest in critical care medicine. Our second speaker is Dr. Ebrightand, and Dr. Ebrightand joined Stamford Hospital and Columbia University Medical Center after serving on the faculty at Boston University School of Medicine. He was the director for their Thoracic Oncology Center and co-director of the Lung CyberKnife program. He has numerous publications in peer-reviewed journals and has even authored book chapters on a variety of topics related to thoracic surgery. And he has also been selected as a Castle Connolly top doctor in Boston, New York, and Connecticut magazines. And last but not least, we have Dr. Paul Weinstein, who I believe has presented to this group in the past. He has spent over 40 years caring for patients with cancer and blood disorders at Stamford Health, and he specializes in treating breast, lung, and colon cancer. Dr. Weinstein first received his training in hematology before joining the growing fields of oncology, and he is dedicated to his patients, partnering with them to develop personalized treatment plans. He uses all the resources available, including numerous clinical trials and robust research here at Stamford Health to help each patient achieve their treatment goals. He's the medical oncology and hematology medical director here at the Bennett Cancer Center. And through the center's affiliation with Dana-Farber, Brigham and Women's Cancer Care Collaborative, he helps bring the most advanced cancer care to patients at Stamford Health. As co-director of the Cancer Risk and Prevention Program, he also helps patients and their families understand their genetic risks for cancer. Based on their genetic test results, he helps families develop plans to prevent cancer or detect cancer in early stages. So we have a fabulous group of speakers today. Thank you so much for having us. And Dr. Bernstein, I believe you're kicking it off. Are you on the call? Dr. Bernstein, I think I see you. Hi, Dr. Bernstein. I think you just have to unmute yourself.
The most famous word of 2021 was apparently unmute. Do you need me to do my slide? How do you want me to deal with my slides?
I can advance the slides for you, or if you would like to share your screen, that's also an option.
Let me see about how to, hold on, share my screen. That way I can advance myself.
Great.
Let's try this for a second. Oh, I need a, my name says Emma on it. Hold on. Oh, why don't I'll just have you advance the slides.
We can see the slides.
Yep, go ahead whenever you're ready.
Oh, for me to share my screen?
I'm sharing it.
Oh, you're sharing. Okay.
Can you see?
I can see him. Yep.
Okay, great.
Just trying to- Oh, so I'm still sharing my screen, right?
We're sharing Amy's screen.
Okay.
Can you see my screen?
I can see you. I can't see your screen.
We can see the screen.
They can see it.
How about that? Oh, I can see. Can you advance the slide, Amy?
Yep.
All right. That's the best way to do it. I can see my own slides then very nicely.
Go ahead.
Oops. Now I'm no longer known as my daughter, so that'll work better.
Are you waiting for something?
He can hear you.
Hello, Dr. Bernstein.
Hello? Oh, what was the question?
Are you presenting?
Oh, are we? I thought we were starting at 11. I apologize.
No, you can go ahead.
Oh, okay.
Yeah, you're good.
Sorry, a little bit of a rough start there. I apologize.
No, it's okay.
And so let me get this right. I just want to make sure you're advancing the screens, right?
Yep.
All right, so why don't we go back to the first slide? And Sorry, I am waiting. I try to get my screen to view. I'm stuck on a very small. Yeah. I've lost all the slides. Hold on.
Doctor, why don't you just talk off the cuff? What's the difference?
We're seeing a slide that says how the CT scan its spots.
I think you're on mute.
I'm on mute. I'm just trying to advance the slides. It's the only.
I'm advancing the slides.
So you'll advance the slides. So now I'll get going. I
Yep.
apologize.
You're
for a little
good.
bit weird. So I want to thank everybody for starting. I'm Mike Bernstein, one of the pulmonary critical care doctors over at Stamford Hospital. And I'll be the one to kick off the morning talks. I'll be joined by Dr. Michael Ebrightand, who's one of the thoracic surgeons, and Paul Weinstein, who is a medical oncologist who does a lot of work with lung cancer in particular. Over the last year, I'm very excited to get a chance to talk about lung cancer again, because I spent the majority of the last 15 months as a COVID doctor, like most pulmonary critical care doctors. And anytime I get a chance to not talk about COVID in a forum is very exciting to me. So we'll go to the next slide. So what I was going to talk about is lung nodules, and how I called it was how the CAT scanner got its spots. So this is a little pun and steal from Rudyard Kipling and the Just So stories. I have young enough kids to remember reading those. And CT scans are very frequently show something called pulmonary nodules or lung nodules, which are spots and dots on a CT scan. And the ability to distinguish these as cancerous nodules is really something that we as lung doctors spend a good majority of our time. There's a lot of interesting research and things going on this field, and I think it'll be exciting to talk about it. Next slide. So what I want to do is answer 4 questions today. So of course, if you have Bernstein, Weinstein, and Ebrightand, you're going to go through a mysterious 4 questions here. But mostly, what is a lung nodule? Why are lung nodules so common, and why do they seem to be increasing over the last few years? How can we tell if a lung nodule is cancerous? And most importantly, are there any better ways to evaluate lung nodules that are coming down in the future? Next slide. So what is a lung nodule? And this is always a little bit of a hazy definition, but the strictest definition is a lung nodule is anything that's a focal density seen on a chest x-ray or CT scan that's defined as being less than 3 centimeters or 30 millimeters. The CT scan on the right of the screen shows a nodule if you look at the far right, and those are what we are frequently talking about. They occur in about 1% of all CT scans and about 0.2% of all chest x-rays. The number and frequency of how often they're seen is related to the group of patients you are screening or looking at in terms of an evaluation. So the older the patient population, the more frequent these will be. And we know again that about 1 to 10% of nodules end up being malignant. And that number varies tremendously based upon the group of patients that are being screened. If you're looking at patients who are very high risk for cancers, that number will go up. If you're looking at patients who are lower risk for cancers, it goes down. Next slide. So what are lung nodules and what cause most of them? The way I like to explain it to most patients in the office is the lungs are really on the outside of the body. You can take your hand and go directly in and grab the lungs. Lungs are exposed to the environment, and just like our skin is exposed, and we have all kinds of little nodules or moles or dots and rough things that can happen in the lung. And so given that you'll see infections or inflammation or other benign findings causing nodules, many are just blood vessels that appear as a abnormal way. But of course, looking for malignant tumors or metastases from other tumors in the body is really what is the most important issue to look at. Next slide. So understanding why lung nodules have become more common and understanding why they're more frequently seen really is integrally related to the importance and the rise of CT scanners over the last 50 years. And it's always a fun little story to mention that CT scanners are intimately related to the Beatles. The original developer of the CT scan was Sir Godfrey Hounsfield, who was a British physicist who was working for a company called EMI, which is sort of a post-war British multi-industrial company. And part of what they did was work on all kinds of new medical equipment, but they had a small group that actually owned record labels. They were a successful company coming out of the late 1940s and into the 1950s, but by the 1960s, they had started to lose money and were not nearly as profitable as they were. Next slide. So in the late 1950s, their research was drowning out, and fortunately for EMI, they signed a little British band with 4 guys from Liverpool, England, and that money from them was able to continue to fund EMI for the first part of the Beatles' career. Ultimately, they left EMI to create Apple Records, but the money they left behind was used by Hounsfield to develop the CT scanner, which ultimately was released to the public in 1972, and later in that decade, Hounsfield won the Nobel Prize for CT scanning. Next slide. So the CT scanner is where we really find pulmonary nodules. Next slide. Why is this? Because the CT scan is basically a great magnifying glass on a chest X-ray. So if you look at the picture here, on the bottom left of the screen for most people, you'll see what I circled in red is a pulmonary nodule, and that is any density on a CAT scan or chest X-ray that's less than 3 centimeters. Up top is that very same chest X-ray, which is a completely normal chest X-ray. So it's not uncommon that patients can have nodules that are not detected at all until they have a CT scan. It really wasn't until the CT scans became more prominent, you could advance to the next slide, that we see a lot of nodules. So this is a graph in the United States over the last 20 years or so of the frequency of CT scan trends in the US. And you can see, particularly for patients over the age of 65, which I imagine is a lot of people listening today, the frequency of CT scans done per year has increased 3-fold in this group. It's increased in everybody, 2-fold in the patient population under 65, but it's really grown dramatically. And as you increase the number of CT scans, you'll see more, you can go to the next slide, you'll see more pulmonary nodules being found. So why are there so many CT scans being used nowadays? Well, they're used for a lot of different examinations. One of the ones that's most frequently occurring and occurring more and more over the last couple of years is to evaluate for coronary artery disease. And this is something called a coronary calcium CT score. And this is a easy way to look at the coronaries around the heart to see their chance of having atherosclerotic disease. It's often used in lieu of having to have a cardiac catheterization. It's much less invasive. And when you do a coronary CT, you're getting a picture of the heart, but of course, the more important organ around the center of the chest, the cardiologist may disagree, but are the lungs, and you'll get a picture of them around it. And we frequently see nodules on those CTs that need to be evaluated. A number of other cardiac procedures, including atrial fibrillation ablations, or for the placement of percutaneous aortic valve replacements, something called TAVR, have gone dramatically up. All those require a CT scan to plan for the procedures. And we know that patients who've had other cancers are living longer and surviving longer. And those frequently require CAT scans for monitoring and following up the disease, as well as looking for blood clots. Really the gold standard now for at least the last 20 years has been a CT of the chest. All these add up to more CAT scans being done, not necessarily with the intention of looking for cancers, but they result in finding more nodules and potentially more cancers as well. The last one that's driving this up are lung cancer screening CTs. And I'm going to defer to Dr. Ebrightand, who's going to talk about this as the second half of this talk, but those all require a low-dose CT scan, and the management of those nodules and distinguishing what is benign and what is malignant is really the heart of a good lung cancer screening program. So just advance one more slide here to end the Beatles discussion here. The number of CT scans in the United States has gone dramatically up. The number of album sales has gone dramatically down. So had EMI stayed in the business, they might have been better to continue to make CT scanners and to continue to make albums, as I'm pretty sure my children have no idea what a record album is, less idea what a tape recorder is, and even less idea, even in 2021, what a CD is, because everything they listen to is electronic. Next slide. So the second question that's really out there and always the most important for lung doctors like me is how to evaluate a lung nodule. And really the question out there is how to figure out if a nodule is malignant. And the way we've always done this is looking at demographic risks. So we look particularly at the patient's age, at their smoking history, how much they smoked and how long they've smoked and how many years since they smoked. We'll look at whether they have a history of another cancer, which is obviously incredibly important if you're trying to figure out if there is metastatic disease to the lung. There are certain job risks that increase your risk for lung cancers. Most of those are environmental exposures to things like dust, silica, and the most famous being asbestos. And family history probably plays some role in lung cancer, not as much as it does in other tumors, and this is always being worked out. If we look at the patient, the other question we always look at is what does the nodule look like? So clearly the larger, the more likely it is to be malignant. There are certain shape descriptors, and where it is in the lung can often make a difference as well. The picture on the right there is a famous picture from the New England Journal of Medicine, and this is a patient having an evaluation for a pulmonary nodule, and you can see in the bottom left, which is actually the bottom right lung, a pretty suspicious nodule that would make you worry about cancer. For a pulmonologist like me, I also look at this and there's a significant amount of emphysema in the background, which again makes you worried. But for everybody else, if you look at the top right corner, you'll see cigarettes in that packet there. That's cigarettes right on their chest, right up there. And if you count out, I think the last time I did this, there's 19 cigarettes. So given there's 20 in a pack, this person probably had one cigarette that morning before their morning CAT scan. Now, if every CAT scan was as easy as this, it'd be easy for guys like me to figure out which ones are benign and malignant, but not everybody wears their history so clearly. Next slide. So when we look at a CAT scan for a lung nodule, we really ask ourselves as lung doctors, what are we going to do about this? And really there's generally three big conclusions. One is we get another CAT scan in a few months, and there's a series of guidelines I'll mention in a moment to figure this out. The second is we try to biopsy the nodule. So there's two ways of doing this. One is through a bronchoscope, which is through the inside out, and that's what guys like me do all the time. Or the other one is percutaneously, meaning going through the skin, and that's often done with their ultrasound or CT guidance. Ultrasound lung doctors can do. CT guidance is done by radiologists. And then the last one is sometimes they're so suspicious and so likely to be a cancer, we just recommend that they be resected right away. We call that surgical resection, and often surgical resection and cure. That's what doctors like Dr. Ebrightand do. And you can make the diagnosis and treat the disease at the same time. And the way we do all of these and to adjust them is all based on a statistical approach using the patient's demographics and the characteristics of the nodules. So these are two charts. They're meant to a little bit confuse you because they're certainly meant to confuse me. And these are the most common guidelines we use as lung doctors. So one of them is from the American College of Chest Physicians. The other is something called the Fleischner guidelines. I like to think of these as looking like an NCAA tournament bracket mixed with a complex legal document, and it leads us to a conclusion as to what's the right test to do for the patient. Next slide. More frequently, we don't just use documents like that. I actually have an app on my phone, and that's what I plug in all the numbers to, and it really comes back with a percentage or a likelihood that this is malignant and will help us lead to informing the patient and coming up with a good decision as to what the next steps should be. Next slide. Now, these are all demographically and descriptively driven and evaluation models. And unfortunately, they do come down to what we do in the rest of society in a lot of ways. So sort of like betting on a horse, or if you're into baseball and other sports that use heavy metrics now to evaluate player talent, or even investing in stocks, you're looking at statistics and guidance and previous trends to help you make your next decision. But next slide. As Mark Twain would say, there are always three kinds of lies, damn lies, and statistics. And this is really one of our issues for pulmonary medicine, is we're using previously used statistics to drive to figure out the next thing. So ultimately, these three conclusions and the sort of standard model we've been using for the last 40 or 50 years is we'll try to evaluate the patient using those models, lump them into three categories, either low, intermediate, or high risk, and then we go on to the next treatment. Low or intermediate risk, we usually will recommend another CAT scan, either in 3 months, 6 months, 12 months. They sort of have a series of guidelines. If they're in between risk, or they're high risk and high risk enough that we feel going to direct surgery would be difficult, we'll try to biopsy the nodule or sometimes even get a repeat CAT scan. And again, we'll biopsy using either a bronchoscope or a CT scanner. And then if the patient demographically and descriptively comes up as high enough risk, we'll recommend going directly to surgical resection. Next slide. Now, the problem with this is we know from a number of models, we're not actually as good at this mathematically as we'd like to think we are as lung doctors. So 3 of the most famous models out there, and I actually use one called the Mayo model, and I have that on my phone, and every time I see a patient, I plug the numbers in, and these will give a number of how likely it is to be a cancer. What this shows is taking the Mayo model and comparing it, Mayo, another one called Gould, another one called Brock, compared to what we call PAR, physician assessed risk. So how good are the doctors just sort of at their gestalt, licking their finger and guessing how well it is to be a lung cancer. So the first thing to note is actually the doctors tend to be better at guessing this than any mathematical model that's ever been put out there. But importantly, for the lowest risk patients, which are the ones that we don't want to have too many procedures on, we often overestimate how likelihood of a malignancy. And if you go to the far right for high risk, where all 4 of those bars should be in the top in the gray, we often underestimate how likely it is to be a malignancy and defer or delay procedures in general. So anything we can do to get ourselves better at lowering the low risk and better at raising the high risk would help patients ultimately figure out what of all these spots and dots ultimately end up being cancers. Next slide. So that leads to the last part here to talk about is, can the leopard have personalized spots, or can we do this better? So imagine looking at that leopard's tail. I was thinking about that this morning and trying to figure out which of those spots are actually cancer and which of those spots are just bread and butter leopard spots. And the best way to think about doing this is, could we add something that's more personal, like a blood-based test or an easily reached tissue, not one that requires a full biopsy to get the answer? And the answer is yes, almost. There's a number of tests that are out there. Some are in early stages of FDA approval, and we're actually part of a number of trials at these at Stamford Hospital, and 2 of them I'm going to talk about. One is called an Oracle test, which is from a company called Biodesics, and the other is the Noble trial from Veracyte. So next slide. So can you do a blood-based test? This would be really the nicest way to help risk stratify patients and not have us just sort of go through computer models or just say, yeah, I have my gut feeling is this is a cancer, or my gut feeling is not. So what I pulled here is actually the way the reports of this blood test work. So this blood test looks at 2 proteins that are circulating in the blood, and through a lot of sort of complex computer learning and large sample size, they've been able to have a predictive model with a high degree for this one of sensitivity, meaning you're able to rule out that patients don't have cancer. The test doesn't necessarily tell us if they have cancer, but knowing that the majority of lung nodules are benign, if we can reduce the chance, will come down. This is actually the report from a patient from just a few months ago. And if I put all the numbers in the computer, it would say he has a 22% risk of having that nodule as a cancer. To tell somebody we're going to wait a year and get another CAT scan, or I don't want to biopsy it, it's too risky, at a 22% risk is something a lot of people don't want to take. So we send off a blood test and it comes back. What it does is sort of look at the pre-test probability, actualize this through the blood work, and then look at the post-test probability, and it reduced it all the way down to a 2% chance of being malignant. And on that rate, I think I'm comfortable as a physician, and I know in this patient in particular, we were low enough to say, let's wait and get another CAT scan, seeing what will happen. Next slide. The question is also, can we do this with other tissue in the body that might be even a little bit more accurate than just blood? And one of the other ideas here is looking at respiratory epithelium. So we know that lung cancers start deep in the lung from abnormal tissue that has a mutation that develops and then grows through time. So lung cancers are started well before they're ever clinically evident. And the area around a lung cancer will have what we call a field of injury concept. And this is worked out mostly by a researcher at Boston University named Avi Spira, who now works with Johnson & Johnson. And it's been well known for a couple of years with tests that are actually in clinical use, that if we rub the airway during a bronchoscope, so we go down to the center of the lung, if the diagnosis we can't make on a biopsy, we can kind of rub what looks like a little toothbrush in the lung and pull those cells. We're really accurately able to assess what the risk of lung cancer is in that patient. And so if the patient comes back as a high risk, we'll refer that patient directly on to surgery. If they come back as low risk, we'll feel more comfortable with waiting again, similar to how the blood tests work. And this is the result of how we can do it from a bronchoscope called a Percepta test. And it's very useful, again, to knock patients to a lower risk as well. Next slide. Ultimately, doing bronchoscopy is something that's enjoyable and fun for guys like me, but for patients, if you don't need to have it, it's something we try not to do. And so can we rub their nose? We know that the tissue in their nose will have similar profiles to tissues in the lung. We were starting a trial on this in February 2020, and we were trying to figure out how to explain this to patients. Fast forward 15 months, it's kind of like a COVID test in your nose. If you've ever had a COVID test before, it goes pretty high up and not that comfortable. This is just on the lower part of your nose. And this can help us just give a number for how the risk of malignancy is, similar to how we do it. And so ultimately patients are brought either high risk or low risk. Next slide. And this is sort of fresh off the press. This was presented at the major oncology conference in June called ASCO. And for lung doctors, this was a really big development. They presented their data that showed they could detect patients and classify them as high risk and have an over 90% specificity that it's lung cancer and directly refer patients to surgery. For lung cancer physicians and surgeons, we know they're going to send some patients for surgery just on guesses that are going to be benign. And having a 90% specificity is better than we could ever get as doctors in our assessment risk. For low risk patients, those would come back as saying that's less than a 5% chance of malignancy. This is where we want to say that you don't have cancer. The statistical term is sensitivity. And here it's greater than 96%, which would make most of us feel really comfortable to sit and wait for a year. Next slide. So I'm going to conclude here as we move on to talking more about lung cancer screening, but just to think about how, as I like to say, how CAT scans got their dots. So this is one of these fascinating topics in the history of medicine that a technology or procedure has really facilitated the diagnosis and increasing the prevalence of a disease. Did people have nodules before? Certainly they did, but having more access and more frequency of CAT scans has led to a proliferation in the diagnosis of lung nodules. I think over the next 3 to 10 years, we're certainly going to push evaluating lung nodules with personalized or genomic testings, because that will help us distinguish what are benign and malignant diseases. And bearing in mind that low-dose CT screening of the chest is the most important tool for detecting early lung cancers, and knowing that combining CTs that are going to show nodules and combining tests that will help further elucidate what the risk of these nodules being malignant will help us to find more patients with treatable and completely curable lung cancers in the future. So I think I'm going to stop there. I think we're going to wait for questions at the end, right?
Yeah, so we'll keep moving through the presentations and hold the questions for the end. But I believe you can use the chat feature to type in your questions as well if anything comes up as the presenters are speaking. Dr. Ebright, are you on the line?
I am on the line.
Great. Would you like me to advance your slides, or would you like to screen share?
I think you did such a great job with Dr. Bernstein, so I think you'll just keep doing it for me.
Sounds great. All right, take it away.
Okay, so I had a little technical difficulty, so I'm not sure if there were introductions of everybody at the beginning or not. I am a thoracic surgeon, so I'm a chest surgeon at Stamford Hospital and at Columbia. Most of my practice is actually lung cancer and esophageal cancer. So this is sort of my bread and butter, just like it is Dr. Bernstein. We work together quite frequently, as we do with Dr. Weinstein, who you'll hear from soon. And I thought Dr. Bernstein did a fantastic job with that last talk. He's actually really on the forefront of a lot of new technology for evaluating risk factors for pulmonary nodules. So we talk with each other pretty much every day. Anyway, I first of all like to thank the Senior Men's Association of Stamford for inviting us today, and I was asked to discuss lung cancer screening. This is a pretty complicated subject, but it's also very exciting. I'm going to try to kind of discuss everything so it's easily relatable and relevant to everybody, and we'll do our best to tackle it in the next 15 minutes. So we'll start off with just a little bit about lung cancer, because Mike Bernstein was talking more about lung nodules, and of course we worry about them because they could potentially be cancers, although most of them are not. But let's talk about lung cancer. Lung cancer actually counts for the most cancer-related deaths in both men and women. In men, it's not prostate cancer. In women, it's not breast cancer. It's lung cancer in men and lung cancer in women. And in 2021, there's going to be an estimated over, about 230,000 new cases and 140,000 deaths in 1 year. And that actually amounts to 22% of all cancer deaths in this country. Next slide. And this is put out by the American Cancer Society. This is actually death rates. I know this sounds pretty morbid, but we're going to kind of turn this on its head when we talk about what we can do to help us all with lung cancer. But what we see here is cancer death rates in men, the highest number of deaths nationwide compared to other cancers. And I can't really show you on the screen because I'm not there in person, but you can see the blue line that creates that big hump. Thank you very much. That is lung cancer death rate, and the lines just below them, that's colorectal cancer and prostate cancer. You see, lung cancer far outweighs those other cancers. And you also see what's interesting is that the lung cancer death rate really peaked in the early 90s. You see on the bottom that x-axis is years, and it really peaked in the early 90s. And the reason for that is this pattern mirrors a decrease in smoking rates over the past 30 years. I mean, the top 3 causes of lung cancer are smoking, smoking, and smoking. So we really did a great deal of progress in decreasing lung cancer rates by helping decreasing our smoking rates. And I'm going to show you the next slide, which is the same graph in women. Lung cancer, again, far outweighs the other cancers. You see breast cancer is that gray line, which is pretty far below the lung cancer death rate line. But more women die of lung cancer than any other type of cancer. But you see the rate of lung cancer deaths reaches a plateau here in the early 2000s, as opposed to the early 90s. It's a later plateau than that which was reached in men. And so it also reflects that smoking rates decreased later in women than they decrease in men. Why is that? We'll go to the next slide. And here you see an ad in a magazine when we used to have cigarette ads all over the place, but those Virginia Slim ads were quite effective. Here they depicted cigarettes as mature, as glamorous, as sexy. This woman has since traded in her roller skates for a rolling walker, and she now has coronary artery disease. She has peripheral vascular disease. She's coughing up a lung in the pulmonologist's office. She doesn't look anywhere near as attractive as she does in this picture, for sure. But basically, this is what we've done to ourselves. Interestingly, in China, lung cancer is still on the rise. As that nation becomes further industrialized, there are more and more smokers. In fact, 2 out of every 3 Chinese men smoke. And 1 out of every 4 deaths due to disease are due to lung cancer in China. That is absolutely staggering. This next slide is actually also information from the American Cancer Society. Every year they put out a whole lot of statistics. And you see here in men, I've highlighted it on the top, the most common cancer in men is prostate, and the most common cancer in women is breast cancer. But by far, the most common cause of death, cancer death in men, is lung, and by far the most common cause of cancer death in women is lung cancer. So this is a huge public health problem. Next slide. So let's say someone has lung cancer. We like to group those patients by what we call stage. I mean, everybody hears I'm a stage 1, and that's probably not as bad as if someone says they're a stage 4. Well, that's meaningful to us because at the time that we diagnose somebody, we want to know how far advanced the cancer is. And that helps dictate what the proper treatment is going to be. And it also helps us determine what the prognosis is going to be. And so you see, these are actually what we call survival curves. So on the vertical axis, it's number of patients that are surviving, and on the axis on the bottom, that's number of years. So you see at let's say 4 to 6 years, if you're stage 1, that's the top blue line, you've got about an 80% chance of survival at 5 years. That's not terrible. And that includes people that may get hit by a bus too. And at the very bottom, at like the blue lines and the black lines, that's much more advanced cancer. Those patients don't do very well. So we look at that. But what we do see is that we want more patients to be discovered at that stage 1, where we can have a meaningful hope of cure, rather than once lung cancer spreads, usually it spreads to lymph nodes first, and then can go to other places in the body. We want to catch the cancers before they get there, when we can really intervene. I mean, lung cancer, actually, let's go to the next slide, because that's a little more illustrative. So basically, the majority of lung cancers currently are discovered at very late stage. And that's because a small early stage lung cancer doesn't cause symptoms. You don't get a big cough, you don't lose weight, you don't have pain from an early stage lung cancer. It's basically not really detectable. Whereas by the time a lung cancer may cause symptoms, it's usually at very late stage, and at that point, it's generally incurable. So lung cancer gets a terrible name because it's usually discovered very late. But in reality, when it's discovered early, it's quite curable. And oftentimes it can be cured without even using chemotherapy or radiation. It can be cured with surgery alone, which we can do minimally invasive nowadays, with small incisions in between the ribs, without even spraying the ribs, with a robot or with video cameras. So because, in Amy, maybe you can put a little arrow over that pie chart where it says 15%. Currently, only 15% of new lung cancers are discovered when they're early stage. Okay, that's the problem. We need to increase that portion of the pie where patients are discovered early and we can meaningfully treat them. So currently, the overall 5-year survival, number of patients surviving 5 years with a new diagnosis of lung cancer, is only 17%. That's terrible. But if you're discovered early, your survival rate can be in excess of 80%. So that's what we need to do. We need to find these tumors earlier. So let's go to the next slide. So how do you find cancers earlier? You got to do something called screening. And we kind of know about screening. We know that we use screening for breast cancer. We get mammograms. Prostate cancer has had some controversy, but we may get a blood test called a PSA. You get an exam in the office. With colon cancer, you may have gotten your colonoscopy. That's always fun. I had mine. It was terrible. But it actually wasn't terrible. I didn't like the prep, but the procedure was a great sleep. But anyway, so what is screening? Screening is an intervention. It's applied to a normal population. You don't screen patients that are in the middle of having a disease. You don't screen patients if they're coughing up blood. You're not screening them for lung cancer. You're finding out why they cough up blood. But screening is an intervention applied to patients who don't have symptoms. And the goal of screening is to benefit the population, the entire population, not necessarily the individual. So for instance, if a woman is going to get their mammogram, right, they have to take time off work. They got to drive to the mammogram place. They got to undergo an unpleasant procedure. They get exposed to radiation. They have anxiety, only to find that they don't have breast cancer. That did nothing to help that individual person at all. Or worse, they may even undergo a painful biopsy also to find out that it's not breast cancer. But when you look at the population as a whole, you're saving lives of the population. So the goal is to benefit the population. So you've got to weigh the risks to healthy individuals against the benefits to those found to have disease. So that's sometimes a hard concept to wrap your head around, but it's important. It's really a statistical analysis. So the value of screening is linked to the likelihood that the target population will develop the disease. And the target population for lung cancer might be those people who are within a certain age that smoke a lot. We're not screening 12-year-olds for lung cancer. We don't screen men for breast cancer. That doesn't make any sense. And then you also have to look at what is the effectiveness of treatment. So to put it in light of a different type of a cancer, let's say pancreatic cancer. Pancreatic cancer is rare. And pancreatic cancer doesn't have very effective treatments once they're discovered. So it doesn't make a lot of sense today with our current technology to screen for pancreatic cancer. Whereas with lung cancer and breast cancer and colon cancer, we have very effective treatments when these patients are discovered early, and they're relatively common cancers. Next slide. So we've been toying around with concepts of screening for lung cancer for many decades, and we've used, in general, chest x-rays to screen for lung cancer. And as Dr. Bernstein showed you in his earlier lecture, because I was paying attention, he was talking about how chest x-rays are sort of more of a broad stroke. They don't really give you details. They're not that magnifying glass in the lung. And you really can't find a small early stage lung cancer with chest x-rays. And we discovered this because we studied this ad nauseum to look at whether chest x-rays can be used to screen for lung cancer. And they don't work. So along came a trial called the National Lung Screening Trial, which was funded by the National Institutes of Health, which enrolled 53,000 patients at many different US medical centers and took patients with a higher likelihood of disease of lung cancer. So you took patients aged 55 to 74. They looked at patients with a 30-pack year smoking history. So a pack year is smoking like 1 pack a day for a year is 1 pack year. 30-pack years is smoking 1 pack a day for 30 years, or maybe 2 packs a day for 15 years. That's a pack year. And then they have to have been either active smokers or quit within the past 15 years. And we took those patients and we did CAT scans on them. We didn't do the normal CAT scan. We gave a lower dose radiation CAT scan to lower the risk of the intervention as much as possible. And then they followed those patients for several years. Okay, and let's go to the next slide. So basically the results of this study were reported in our preeminent journal, the New England Journal of Medicine, in August of 2011. This was a big, big deal. Next slide. And I'm not going to go into major detail here. We'll kind of just hit the highlights. It showed that we were able to reduce lung cancer-related death by 20%. That is a huge number, And they reduced overall mortality in those patients by 6%. So some patients die of other causes other than lung cancer. But even their overall mortality was a 6% reduction. There is a number that we call number needed to screen. Number needed to screen to prevent 1 death, okay? And the number of patients needed to screen to prevent 1 cancer death, you need to screen 320 patients to prevent lung cancer death. That means 319 patients have to go get these scans and not have lung cancer, but they're all doing it because they really like that 320th guy. So that's what's going on. Let's go to the next slide. When this data was further parsed out, and this is a busy slide, I'm not expecting you to look at these numbers, but what we found was exactly what we were hoping for. Actually, Amy, if you hit the front arrow, it brings in 2 additional little jiggers. Just advance it once, see what happens. Yep, and advance it again. Okay, yeah. What we found is that in the group that was screened with scans, 50% of those patients were discovered at stage 1. And when you looked at the patients that weren't screened with scans, they were screened with just chest x-rays, 50% of those patients were discovered in the very latest stage where they have terrible prognosis. So this is exactly what we wanted to see. The patients that were screened, we were discovering these patients early. So that was a huge victory, and it really made logical sense to us that we're now discovering patients. We're changing that piece of the pie to expand the number of patients where we're discovering them early. Next slide. And because of this data, multiple organizations adopted these recommendations. Our biggest organizations in the field of pulmonology and in chest surgery and cancer. Next slide. And just to put that in perspective, that number needed to screen to save that 320th guy, that's our friend in lung cancer. In breast cancer, you need to screen 1,200 women to save 1 life. And in colon cancer, you need to screen 870 people to save 1 life. And we take mammography and colonoscopy, that's gospel to your primary care doctor. You better go for that screen. In lung cancer, you only need to screen 320 patients. Why is that? Because we're very selective about who gets screened. We're only screening the higher risk patients, those of a certain age group and that are smokers, right? And so that helps, but this has to come into our basic national mindset, in our mindset of our primary care doctors, that they need to really be on the lookout for patients that fit that criteria to get them screened. Next slide. So why get screened? Why be one of those 319 people that don't have cancer to save that 320th guy? Well, you want to discover these patients at the treatable stage. You got to realize that screening doesn't prevent disease. It just discovers it early, right? It's not a treatment. And then patients have personal reasons for wanting to get screened. They may have a fear of cancer. They may want relief from anxiety. They may want reassurance that they don't have lung cancer. One of the side effects we've seen is that some patients want reassurance that they don't have lung cancer so they can continue to smoke. That's not a good reason, but we're going to go back. We're going to talk about that in a moment. So let's go to the next slide here. This is a slide. I love this slide, but it takes me a little bit of time to explain it. So is lung cancer screening foolproof? No. In fact, about 3% of patients with negative screens in that trial actually develop lung cancer. So if you think about it, when a tumor that's growing, it starts as a couple cells, and then it sort of starts to grow and grow, and it becomes something that may be detectable on a scan. So a tumor needs to grow big enough so you can detect it on a scan. And of course, once they're symptomatic and the patient's having that problem where they're having shortness of breath or coughing up lung, then you're not getting screened, you're getting an evaluation. But Amy, if you can kind of point out that window of tumor burden between lung cancer, a tumor that's detectable and a tumor that's symptomatic, right? Those green lines, right? And then you get screening, let's say once a year. Those are each of the black lines or the green lines. Those tumors, those red lines there, the red lines are tumors that are really aggressive. They may go from detectable to symptomatic even in between the course of a year, right? So we may miss those cancers on screening if we're screening once a year. Doesn't make sense to screen more than that. Otherwise, you'll have even more patients that get scanned. But those orange lines, which are the moderately aggressive tumors, will be discovered in that interval between detectable and symptomatic. Those are the tumors we're finding. The yellow tumors are the ones that are so slow growing that they may even be inconsequential. We'll talk about those two. Next slide, rather. So what do we do with these positive screen results? We find something on that CAT scan. The rate of finding something on a CAT scan is actually very high. It's 24%. That's pretty high. But most of these, in fact, 19 of 20 of them are actually what we call false positives. They're fake outs. They're decoys, right? Most of those can kind of be worked out by either just getting another scan down the road and finding that it doesn't really change or it disappears. And then some of them need maybe a different type of a scan called a PET scan that answers a different question, or they may undergo some type of invasive procedure like a biopsy or even surgery to figure that out. What we do know is that the complication rates for additional scans and procedures is extremely low, and the benefits of screening far outweigh any complications or problems you have from screening. But this is why screening is an actual intervention. It's not just like a look under the hood and a little bit of information. That's an intervention, and it causes some issues. So let's go to the next slide. What are the risks of screening? Because the actual practice of screening has risk in and of itself. So you have the risk of false positives that we just talked about. You have potential for subsequent procedural risks to investigate these findings, and we just talked about that. You also have a risk of something called overdiagnosis. We're going to talk about that. Radiation exposure, we're going to talk about that. And causing anxiety, we're going to talk about that. But we won't take up too much time. Next slide. Overdiagnosis. This is a really interesting comment, rather a concept. Overdiagnosis is the detection of an actual cancer that would not cause symptoms or result in death over a patient's lifetime. So for instance, if a patient dies at age 90 of a heart attack and they get an autopsy and the pathologist doing the autopsy finds a lung cancer, did that lung cancer ever hurt them? It didn't, right? They lived to age 90. They died of a heart attack. They never even would have known they had a lung cancer. Never hurt them. If a patient has a lung cancer and they didn't know that it was there, and they go across Main Street and they get hit by a bus and they die, that patient never got hurt by their lung cancer. So we may be discovering things that never would have hurt the patient. There are some cancers, like those yellow line cancers I showed you on that graph, that grow so slowly, or maybe even indolent, because there's some cancers that really don't grow very fast, that may never hurt a patient. So one of the risks of lung cancer screening is we may be discovering things and acting upon them and putting patients through a procedure, but they never really needed it. But unfortunately, we can't tell the future. So we can't discover prospectively that a cancer is indolent or isn't going to grow from something that may be aggressive. There are some clues we can use to kind of make some of those decisions, but it's a hard thing to do. So overdiagnosis may occur in almost 18% of patients. That's our best estimate. It's obviously a hard thing to figure out because we don't just watch cancers if we know it's there. But overdiagnosis can result in unnecessary treatment, morbidity, cost, anxiety. That being said, it doesn't argue with the fact that we save lives with lung cancer screening, and the benefit clearly outweighs the risks. But that's certainly one of the risks that we tell patients about. Next slide. There's also the risk of radiation. So, you know, we all get radiated by walking outside and sitting under the sun. Background radiation that we all get every year is something called 4 millisieverts per year. That's a very small amount of radiation, and you just get it just from being on Earth. If you take 25 cross-country plane flights, that gives you an extra 1 millisievert. If a woman gets a mammogram, that's less than 1 millisievert. If you get a standard chest CT scan, that's 7 millisieverts. If you get a cardiac stress test, that's 12. A low dose chest CT for screening is 1.5. That's a pretty low number, right? But it's not zero. The risk of radiation is you could develop a radiation-induced cancer. That risk is very low. So to put it in perspective, for a 50-year-old woman with a 30-pack-year smoking history and gets like 25 years from age 50 to age 75 of annual screening, they increase their risk of a radiation-induced cancer by less than 1%. That's compared with a 17% risk of having a lung cancer. So so being afraid of the radiation is really not a great reason not to have lung cancer screening. Now, would we decide to get a standard full dose CT scan on someone starting at age 6 to age 90? No, that would make no sense. And radiation-induced cancers generally take about 10 to 12 years to develop. So it's not something that we worry about too much, okay? So the radiation risk is low, but it's not negligible, as long as we have a good reason for getting the scan. Next slide. Anxiety. This is a real risk of lung cancer screening. You can get anxiety for having the scan. You can get anxiety for not having the scan. Everybody's a little bit different, but there are potential adverse psychological effects of false positive scans, significant other findings that we see on the scan, like you can get a CT scan of the chest to look for lung cancer. You may find that you don't have a lung cancer, but you have an aortic aneurysm or something else. These are all other things that could potentially be discovered. But the false positives can occur at a rate that's not insignificant. And so the results, and the other thing about lung cancer screening is it doesn't give you a black and white answer right away. Sometimes you get a screen, it shows something, and the doctor may say, you know, we just need to keep an eye on this. Maybe we'll get another scan in 3 months or 6 months. And so then you got a little bit of anxiety that you have until you get that next scan. Some patients handle that well, some patients don't. So that can be a bit of an issue. That's a real issue that I face as their doctor. Next slide. But this was actually studied, and this was a parallel study to that national lung cancer screening trial, and we found that actually there was no difference when you test patients for anxiety by giving them questionnaires. There was no difference between those patients that had negative scans, incidental findings, or false positive scans at 1 month and at 6 months. So the anxiety does melt away with time. And usually, actually, you decrease the anxiety by really just having a good discussion with the patient beforehand and letting them know, like, listen, this is a deal with lung cancer screening. Most of these things are nothing. Sometimes we have to follow stuff. And as long as you sort of set their expectations, it makes sense. Next slide. Yeah, cost of screening. Another thing is cost, right? Now, just to put in perspective, your insurance and Medicare pay for lung cancer screening in total. So the cost of the patient directly is nothing. There was a recent change in the qualifications for lung cancer screening, so there's a bit of a correction right now with what has to happen for some patients at the fringes of eligibility, but we're going to fix that. But generally speaking, lung cancer screening should be free to people. But there is $1.3 to $2 billion of national healthcare expenditure that will be added to avoid 8,100 premature cancer deaths. How much is a life worth? That's really not a question for a doctor to answer, right? But that's the cost. So the additional cost of screening to avoid one lung cancer death is $240,000. So you look to the guy next to you, and is he worth $240,000? That's the question for the government to answer. That assumes that screening uptake of 50 to 75% of patients who are qualified for lung cancer screening. We're well below that right now. Next slide. We talked about smoking cessation, right? We don't want to use lung cancer screening as an excuse to continue smoking. That doesn't make any sense. So I cannot stress this first bullet point enough. The most important tool for preventing lung cancer death remains smoking cessation, right? I'd much rather you quit smoking than get lung cancer screening. I don't want to use lung cancer screening as an excuse to keep smoking. But oftentimes lung cancer screening can be considered what we call a teachable moment. You have that interaction with the patient that's still smoking to try to convince them not to, or they may even have a spot on their lung cancer screen that scares them into quitting smoking. What's amazing to me, and what's probably amazing to Dr. Bernstein, is how addictive cigarette smoking really is. It is amazing. I have patients that have had lung cancer. They may quit for a few months, then they're back to it. And they knew that it caused lung cancer. They knew that they can get another lung cancer. It's amazing. But you really have to want to quit smoking to quit smoking. Several studies have shown that there's a cost effectiveness of lung cancer screening that may be significantly augmented by a partner smoking cessation program. We have one at Stamford Hospital with our very, robust lung cancer screening program. We have a program called Commit to Quit, and it works very well. And everybody who's smoking is invited to participate. Next slide. Here's a quick picture of a lung cancer screening scan. You see at the bottom of the left side of the screen is actually the right lung, but that's that spot right there. Thank you. That spot right there is a lung nodule that looks by its shape and by its location like a cancer. Okay. This was a 61-year-old gentleman who was a 40-pack-year smoker, quit 3 months before this scan was done and had this spot that's about 1.5 inches big. Next scan. Next slide. So this would, this has had a probability of lung cancer of well over 15%. We recommended a further workup, which he got. I operated on this patient with a minimally invasive operation. He did well, and it showed that he had a 1.8 centimeter, which is about, about 1.5 inches of an adenocarcinoma, which is a type of lung cancer, and it was discovered at the earliest possible stage. So this we would consider a lung cancer screening success. We hope to have cured this patient. This patient did not need chemotherapy. This patient did not need radiation, surgery alone. If we had not noticed this cancer, the most likely scenario is the patient would have been dead in 2 to 3 years. Next slide. And we're almost done. So the most current criteria for lung cancer screening, this is probably the most important slide, ages 50 to 80 years old, patients with at least a 20-pack-year smoking history, so smoked, let's say, 1 pack of cigarettes for 20 years or half a pack of cigarettes for 40 years, 2 packs of cigarettes for 10 years, however you want to split it up. And they have to have been either a current smoker or quit within the last 15 years. So they recently quit or a current smoker and not having symptoms, because if you're having symptoms, you will look up the symptoms. So those are the criteria. And if you or your friends have any of these criteria, they should absolutely get lung cancer screening. Next slide. So in summary, we know that lung cancer is the leading cause of cancer death in the United States in both men and women. The National Lung Cancer Screening Trial demonstrated a 20% reduction in lung cancer mortality when applied to a high-risk population, those smokers. And lung cancer screening programs should be instituted as part of a multidisciplinary team. So when we have our group, we have pulmonologists, radiologists, thoracic surgeons, nurse navigators, all working together. And programs should be paired with a formal smoking cessation counseling program. That's all I've got. I think we'll do the next talk and then we can take questions, and I'm sticking around. Thank you so much.
Thank you, Dr. Ebright.
Well, I'm Dr. Paul Weinstein. I'm a medical oncologist at the Bennett Cancer Center, and I'm pleased to be with you again because I gave a presentation to your group a couple of years ago. I'm going to talk about advances in lung cancer therapy, but the whole point of what you just heard is to make me unnecessary. So let's keep that in mind. So where do I push that? Oh, okay. So let's talk about what cancer really is biologically. So we know that cancer is a genetic disease. I don't mean that it's hereditary, although occasionally it can be, but we do know that cancer is caused by damage to or malfunctions of important genes that control vital cell functions that affect how a cell may divide and proliferate, or there may be damage to genes that protect the integrity of their DNA. And as I said, more often than not, these damages, these mutations are acquired rather than inherited, although some may be, not particularly in lung cancer, but of course we get concerned about this in breast and ovarian cancer. Cancer is characterized by the inadequacy or the failure of signals, and then these signals are principally proteins and enzymes that regulate important cell functions and abilities. And these signals may be either insufficient or inadequate. They may be dysfunctional or not functioning at all. Now, none of this exists in a vacuum. So we know that cancer is influenced by the biological and molecular environment in the patient. Other things may be affecting these damage induced by some of these mutations. Some may actually be protective. I'd like to learn more about those, to tell you the truth. And effective cancer treatment aims to induce cellular cancer cell killing or inhibition of their growth, or to encourage them to commit suicide, a process called apoptosis. So I don't have to remind you that this stuff will kill you. We know that tobacco is the most preventable cause of cancer, accounts for about 1/5 of all worldwide cancer deaths and almost 1/3 of American cancer deaths. 50% of smokers will die of tobacco-related disease, and it will cause them on average to lose 13 years of life compared to non-smokers. Now, don't think that tobacco causes only lung cancer, because it's related to the genesis of many other kinds of cancers as illustrated here. So stay away from this stuff because it's a poison. So biologically, we know that cells, both benign and normal cells or malignant cells, receive information about what to do by growth factors, things that may stimulate certain cancer cell or cellular activities. We also know that these cells receive information from their surrounding tissue, as well as contact with other cells nearby. Again, this doesn't occur in a vacuum, because these signaling pathways are not isolated from each other, but they're interconnected to form very complex arrangements. And then the cells must integrate all of this information to regulate a whole host of different cellular processes and activities, such as the genesis of proteins, the ability to grow and move, the ability to maintain their architecture, and to differentiate, in other words, to become normal and to avoid programmed cell death, that process known as apoptosis. So what are these signals and what do they do? Why are they important? So we know that these signals may allow cancer cells to become in fact, they may generate their own signals so that they can tell themselves to grow. And they may also tell themselves to be insensitive to anti-growth signals. These signals may allow cells to invade nearby tissue and to spread to other organs. They may encourage a limitless ability to replicate themselves. In other words, these cells have progeny that ultimately become immortal. Cells can develop their own blood vessels or cause their own blood vessels to develop, through which they can spread and from which they can derive nutrients, which is exactly what you don't want to have happen. And cells can tell themselves not to commit suicide, so they, again, remain immortal. And this cartoon is really just a very oversimplified schematic illustrating some of the complexity of these signaling pathways. Every one of these little ovals or circles is a target, meaning that this may serve as a target for a therapeutic intervention. And so what is a good target? Well, the ideal biological target is one that is pathogenic for and required for the growth and progression of cellular activity, namely cancer cell activity. And inhibition of that function results in anti-tumor activity, and that's what you want a drug to do. Ideally, the drug should be highly specific for tumor cells versus normal cells. Sometimes the target is overexpressed in a cancerous cell as compared to a normal cell. And if so, that drug, that intervention, will be more likely to affect the cancer cell than the normal cell. And for the purposes of research, we'd like to be able to measure the target in the individual cell. So lung cancer comes in a variety of shapes and forms. The most common type of lung cancer is what we call non-small cell lung cancer. That is roughly 85% of all lung cancers. And the remainder, the 15%, is small cell. Within the non-small cell variety, the most common form is adenocarcinoma, a carcinoma that develops from the glandular tissue of the lining of the lung. Squamous cell carcinomas are a bit less common, but nonetheless very important. Then there's a less common variety called large cell, and about a fifth of lung cancers can't be totally classified histologically. But notice in the next diagram, the plethora of gene mutations that have been discovered in non-small cell lung cancers primarily. The RAS mutations are very common, followed closely by mutations in the epithelial growth factor receptor. And then notice that there must be 15 or 20 others here, all of low likelihood in cancer cells, but nevertheless important because almost every one of them has a targeted therapy. So what are these targets and what are their therapies? So the first target to be developed was the epithelial growth factor receptor. And over the past 15 or 20 years, a number of drugs that we call tyrosine kinase inhibitors, TKIs, have been developed. These drugs get into the inner workings of the cell and paralyze the ability of the cell to go through a whole host of metabolic pathways that would lead to activities that we call cancer. The current first-line tyrosine kinase inhibitor for lung cancer is a drug called osimertinib. And we know that patients who are on osimertinib, if they behave anywhere near what the clinical trials suggested, will have a progression-free survival of almost 20 months. Progression-free survival is the time it takes for the cancer to progress after you start a therapy, or for the patient to die after you start a therapy. So we know that a drug like osimertinib will delay progression and prevent death for a median of 19 months. A less common mutation is in the ALK gene. And so we have at least 2 effective therapies that can also delay cancer progression or slow the likelihood of death by a median of 19 months. And then there are a whole host of other mutations that I've illustrated here that can have similar targeted therapies for them. The most recent development is a drug called sotorasib, which targets a certain type of mutation in the KRAS gene. And again, the RAS gene is the most commonly discovered gene mutation in lung cancer and is the most important driver of lung cancer cellular growth and all of the bad things that cancer cells do. And until just the past year or so, this was considered undruggable. There were no drugs that attacked the KRAS protein, even though we knew about KRAS for 2 decades. But recently, this drug, sotorasib, became available, and it delayed progression of cancer by almost 7 months in people who had been treated with many other treatments before sotorasib was given to them. The hope is that for those persons with a KRAS mutation of this type, that the earlier use of a drug like sotorasib will provide even greater benefits. This is also the era of immuno-oncology. We've known for decades that the immune system is a vital component in the way patients fare with their cancer. Some people think that failure of the immune system or inadequacy of the immune system is what leads to cancer. Well, maybe yes, maybe no. Some people feel that if you can enhance the immune system, you may wind up having an effective therapy. And that's what I'm going to illustrate here. So a cancer cell can make proteins that will inhibit the immune system, as shown by this T cell. A T cell is an important component of the immune system, and when active, it can help to suppress cancer, and when paralyzed, it will allow cancers to thrive. So cancer cells can make proteins that can attach to the T cell and cause the T cell to go to sleep. If you can develop a treatment that attacks the protein that the cancer cell makes and prevent it from attaching to the T cell, you may have effective therapy. Similarly, if you can develop a drug that attaches to the T cell and prevents the protein produced by the cancer cell from binding to it, you may have an effective therapy. And so shown on the right is just an example of that with a drug called nivolumab, which we know is Opdivo. You may have heard about this drug. And so shown on the left-hand side of this graphic is the tumor cell, and it's making a protein called PDL1, programmed death ligand 1, and it plans for this PDL1 to attach to the T cell and put it to sleep. What's shown in the middle is the benefit of the nivolumab, which attacks the PDL1, preventing its binding to the T cell and allowing the immune system to keep doing what it's supposed to do. So if you can't explain it to a 6-year-old, you don't understand it yourself. So I understand it, and I hope you do too. Now, that's the theory. But where the rubber really meets the road is, does this actually work? And so I'm illustrating here 7 or 8 different trials of different immunoactive agents, pembrolizumab, nivolumab, atezolizumab, and the newest one on the block is semoliplimab. I can hardly pronounce it myself, semoliplimab. And so all of these have been studied as single agents or in combination with chemotherapy, and all of them have shown benefits compared to chemotherapy alone. And I've showed you here some of the data that suggests that progression-free survival, how long it took for the cancer to get worse from the time you started the treatment until the disease got worse, and how long it took for a person to live or when they were going to die when they were started on these treatments. And so all of them have been beneficial. And I've just illustrated 3 or 4 of them here. There are many, many more. And one of the most difficult parts of dealing with this is learning how to pronounce their names. But nevertheless, we use them commonly in the right circumstances, and we are achieving good results with them. That's not to say that they don't have their problems, because the way these medicines work is to rev up the immune system to fight the cancer. But sometimes the immune system is not as smart as we would like it to be. And so other normal tissues may also be attacked by the immune system. And so I like to say that you can get inflammation, or as I put it, itis, I-T-I-S, in virtually any organ in the body. So you can get colitis, when the immune system is overactive against the colon, and you can have diarrhea from that. If it attacks the skin, you get dermatitis and a rash. But basically, any organ in the body can get itis. And so the astute clinician has to be aware of these potential side effects and be able to tell them apart from activities of the cancer itself. We're getting good at this and getting better all the time. So Einstein said that everything should be made as simple as possible, but not one bit simpler. But I like to show you what our famous American philosopher said about all of this, because this is really the wave of the future. So pay attention to what Yogi said. The future ain't what it used to be. So thank you very much for your attention. And if you had questions for either of the two Michaels, Bernstein and Ebright, or me, we'll be happy to field them now. So thanks, everybody.
Any questions from the audience?
Guys, if you have any questions, raise your hand with the buttons on the Zoom screen, and one question at a time, please. And we see we have a couple of questions already.
Do I have a question?
All right, let Larry go first, then you, Joe, okay?
Okay.
Larry. go ahead.
Okay, yeah. This is a question from one of our members who could not participate in the meeting today. He asked, what is the incidence of lung cancer caused by melanoma?
Well, lung cancer itself, a melanoma itself does not cause lung cancer, but melanoma, if it's not curable, can spread to the lungs. That's not an unusual place for metastatic melanoma to exist.
And how often does that occur?
Well, the information I shared with you about immunotherapy for lung cancer really came as an outcome from the benefits of immunotherapy in melanoma, one of the very first tumors to be shown to be sensitive to treatment with immunoactive drugs. We know that melanoma is not cured often enough. And when it is not cured, the places that it commonly spreads include the lung, the brain, the liver, and bones. And it's variable. The incidence of whether lung is involved or not involved in a person who has metastatic melanoma can be very variable. And to be honest with you, I cannot tell you the statistic exactly, but only to say that it is by no means unusual for a person to have lung involvement if they have metastatic melanoma.
Thank you.
Okay. Joe?
Yes. On all the slides that Dr. Enright was discussing with the age and the years since quitting smoking, what's significant about the 15-year as opposed to, let's say, somebody that was a heavy smoker and quit 40 years ago?
That's a good question. Yeah, so when they did this national screening lung trial, we studied like 54,000 patients, and that data was sliced and diced every which way. The patients who had quit smoking a long time ago had much less benefit from lung cancer screening because the risk of their developing lung cancer was less. When you smoke, there's a latency period. Your risk of lung cancer continues for a certain amount of time after you quit smoking, and then it starts to trail off. Because if you're going to get lung cancer, you're probably going to get it in the next 10 to 20 years. And so after you reach a certain point of having quit smoking, your risk from having had smoking starts to decrease, or you prove that you're not one of these people that may have a predisposition to getting lung cancer. So the risk benefit is not there. Now, certainly if you quit smoking 40 years ago, but you were a heavy smoker at that time, your risk is not the same as if you had never smoked. But the risk benefit equation for undergoing lung cancer screening really doesn't pan out.
So, Mike, if you don't mind, I'd just like to elaborate on that for a moment. So
Sure.
One of the questions that sometimes I'm asked is, if I stopped smoking 10 years ago, does my risk for lung cancer drop off to as close to zero as it could be? And the answer is no, as Michael pointed out. Even if you did a lung biopsy 15 years after a smoker stopped, that tissue may look normal. But remember that the genetic damage may be immortal. So if you've damaged your genes by smoking and those cells proliferate, and every daughter cell and every granddaughter cell and every great granddaughter cell and so on, they may have the same DNA damage. Now, there will be a whole host of other normal cells that may keep the percentage of damaged cells quite low, or the immune system may kick in and get rid of some of those damaged cells. But that's one of the reasons why people may have a late development of lung cancer, even years after they've quit smoking. Nevertheless, it's always a good idea to quit smoking,
Yes.
I just,
or better yet, never start.
Never
I
start.
can't raise my hand normally. One question about marijuana now that is being legalized. Do you anticipate an incidence with lung cancer with people smoking marijuana now that it's going to be legal?
I guess I'll jump in because it's a pulmonologist question. Yeah, a lot of people smoke marijuana. It's very, very common. Unfortunately, there's not great research on this because research has been prohibited to be performed. There are lots of ways of either smoking marijuana or using marijuana. I always like to tell patients nobody is asked to smoke their Lipitor. So it's probably not great to smoke anything. And so it's all a risk benefit of how you're smoking for things like dabbing, water pipes, vaping liquids, vaping gels, rolling joints, rolling hydroponic joints. You can tell as a lung doctor, I spend a lot of my day talking about marijuana. It's probably a topic worth going over for everybody, but there may be some risk, but in general, it's not nearly as high as tobacco.
And he inhales all that
Thank you.
stuff.
Lloyd contract. Lloyd, you're muted. Lloyd?
Larry.
All right,
Okay.
Larry, Lloyd, go ahead.
I saw on earlier charts presented by Dr. Bernstein that there was a PET mentioned versus a CT. And I was wondering what the difference was, what the benefit of having a PET versus a CT, and when do you use either one?
Sure. So a PET or a PET scan is a nuclear medicine test that gives what we call radio-labeled sugar. So we know cancers take up sugars in the body and will glow in areas around cancer. Other parts of the body will glow with cancer, will glow with a PET scan as well. The kidneys always light up, the brains always light up, and in fact, some of the heart tissue will light up as well. Infections will also light up, and even inflammatory tissue can be bright. So it's not specific to cancer on a PET scan. A PET scan is usually in 2021 always combined with what we call a low fidelity CAT scan. So when you do a regular CAT scan of the chest, the patient takes a big deep breath and then it's sent through the machine in about 5 seconds. A PET scan, you have to lay there, I think it's about 20 minutes. So the image quality is not as good. And it actually has a higher radiation risk as well. So a PET scan is not optimal for a screening test for cancer. When we have patients who have abnormal findings on a CAT scan or we're suspecting cancer, we'll combine a PET scan to figure out the optimal place to biopsy or to try to see if the PET scan is not glowing and would thus reduce the risk of cancer probability as well.
Stu, you got 2 more questions, Larry and Ray, and that will be.
Last 2. Okay, Larry.
Yes, I have a relative who's being treated for a lung tumor and an adrenal tumor, and the treatment is currently Keytruda. How effective has the findings been for Keytruda in alleviating the symptoms and maybe curing the cancer?
Well, I'm not practicing medicine for your relative, but we know that the adrenal is not an unusual place for a lung cancer to metastasize. When lung cancers metastasize, it's unusual for them to spread only to the adrenal, and perhaps your person has disease beyond that. We know that pembrolizumab, which is Keytruda, can have a very beneficial effect. For persons who express a lot of that PD-L1 protein, the protein that puts the immune system to sleep, but if they have a lot of it, we can sometimes use a drug like pembrolizumab, Keytruda alone, and we're very good at suppressing and delaying progression of the cancer in maybe up to 1.5 years or so. In certain patients, those who have only a moderate amount of this PD-L1 stuff, combine pembrolizumab with chemotherapy, and that too can be very beneficial in controlling the cancer. Regrettably, this is not a cure. We hope that it might have been, but we have not been able to cure people. We make them live longer, we delay the progression of their cancer, but we generally do not cure them.
Thank you.
Lastly, Ray.
Yes. All the recent research on messenger RNA for COVID, is any of that research applicable to cancer prevention or screening?
Yeah, so earlier I mentioned that cancer is a genetic disease, a damage. We know that toxins like tobacco smoke may damage DNA, and the way DNA works is to then send signals to the ultimate development of mRNA, which then ultimately controls or protein production. And if any of these things are damaged, then the proteins that produced will be dysfunctional or inadequate, and so cancer may develop and thrive. The mRNA technology that's being used in COVID vaccination, to the best of my knowledge, is not applicable or has not been shown to be useful in cancer treatment. Now, we've always had the idea of giving cancer vaccines, something that can be an antibody, a chemical that will then attach to some component of the immune system and sometimes bring a virus with them that will activate the immune system and hope to be effective cancer treatment. But none of those vaccines for lung cancer have panned out to be effective, regrettably.
I can jump in. There's actually a couple things. So one, BioNTech, which is the real maker of the Pfizer vaccine, is a cancer company and not really an infectious disease company. And at least from my perspective in the pulmonary world, there are two things that are going on. One, the entire technology of using mRNA and the stability of mRNA has already shown to pay benefits in lung cancer diagnostics. We always try to biopsy with the smallest, least amount, and just this ability to preserve and maintain mRNA samples has already started. And we have actually a trial going on at Stamford Hospital where we put little bits of tumor in something that's directly related to how they made the mRNA vaccines, and hopefully will allow people to be will allow people to be diagnosed with less tissue. So there's a lot of money in mRNA work in the last 15 months, and it does pay benefits already. As Dr. Weinstein mentioned, the idea of could you make a vaccine, that's what these companies are doing. And it would be very hard to argue that you can make a vaccine that will completely treat lung cancer, because once the amount of tissue is significantly out there, the trials have not proven to be very successful. But there is talk in pulmonary literature and even some early things looking on high-risk patients to develop lung cancer, which would be people who have nodules. Would there be common vaccines for even preclinical stages to treat them? And it may work in patients who have a lung nodule. So you wouldn't even need to know if they have cancer. You just have a lung nodule. We can make a vaccine basically to the most common 5 types of lung cancer, and it may work. So I'm pretty optimistic that actually something pretty cool will come out of these vaccines in the future.
Good. Okay, guys. Doctors Bernstein, Ebrightand, Weinstein, thank you so much for your time here. Very, very interesting and useful information, I think. And Amy, thank you very much for coordinating this for us. And
anytime, my pleasure.
Good, thank you again. Joe, back to you.
Thanks, everybody.
Thank you.
Doctors, Amy, thank you so much for a very informative session, and you can tell by the guys staying on and hanging in there, listening. We're all, informed and interested in the presentation. And guys, this is our last meeting of the season, formal meeting. I wish everyone a happy summer. Stay well, stay safe, and be careful, and hope to see
Joe.
everybody back in September.
Joe,
Yeah,
Yeah. what about a board meeting?
There's none.
there is none.
I thought there was one scheduled.
No?
My error. Thank you.
Okay, we had 2 board meetings since our last board, formal board meeting, and we've covered everything we needed to.
Okay, fine.
Okay,
Thank you.
enjoy the summer, guys.
Thank you.
And hope to see everybody back on September 9th, I think it is. So,
Hope to see you all on the 30th.
well, I mean, on meeting wise. Okay, the meeting is, I
Over.
guess I'm closing the meeting, so.